Welcome to this this Vintura webinar, and it's really great to see. I see the numbers counting up, and there are really so many people that registered, and it's really from around the globe. So I have to say, good afternoon, good morning, and good evening at the same time. So it's really exciting to have you all here. And as you can see on the slide, what we will do today is really discuss our latest Vintura value-based healthcare publication, which is called Value-Based Healthcare: The Answer to Our Future Challenges, or actually, in other words, the sense and nonsense of value-based healthcare today with recommendations for tomorrow. With us today is our four people. First of all, let me really welcome them quickly. First of all, we have Janneke from Kamp, who is head of region Europe at Novartis Pharma, one of the largest innovative pharmaceutical companies in the world, and engaging in numerous value-based healthcare partnerships with key stakeholders in healthcare. Next, we are very proud to also have Villalba joining us from Canada at the moment. She's executive director at Quebec Cancer Coalition. It's a multi-stakeholder coalition aiming to improve the healthcare system in Quebec for the good of those affected by cancer. Then we have another panelist on the line, which is Teus van Laar. He's professor of neurology at the University Medical Center in Groningen in the Netherlands, but mainly joining today because he's also director of research at the Punt for Parkinson, or in English people would call it Point for Parkinson. And that's an organization that is really set up to coordinate and harmonize the fragmented care for patients with Parkinson's disease. Presenter today will be Gerard Klop, my colleague. He's the co-founder and partner at Vintura, a life science and healthcare consultancy. And he's also the main author of all the value-based healthcare publications, especially also this last one. And then finally, I'm here, Casper Paardekooper. I'm also a partner at Vintura and a strong believer in the need to transform our healthcare system to become more value-based. So if I'm not going to talk you through the full detailed agenda, the main thing to remember, we have 3 sections today, where we first have 2 sections on value-based healthcare today. What is it now? What have we learned? Introduced by a presentation, and then some reflections from the panelists. And then we look at how value-based healthcare tomorrow looks like in the eyes of Vintura, and also what our panelists think. And then by the end of the day, we have an opportunity to engage in discussion based on the Q&A with our participants. So you can ask your questions throughout, but we will address them at the end of the day. Some short rules of engagement for today, just to be aware of. Nothing really special, but if you have your questions, please raise them during and after the presentations using the Q&A function that's available at the bottom of your screen in Zoom. If you have a question specifically for a person, please put the name of the question of the person in your question, so we can at the end give them to the right person. Hopefully there will be many questions. Time will be a bit scarce, so there will be a selection. We will take the opportunity to prioritize the questions. So don't be angry, but we have to make some selections, and your question might not be addressed today. As you might have heard, the webinar will be recorded, and you're all more than welcome to also make some noise on social media, Twitter, LinkedIn, and please use the hashtag VBHC impact for that. That's it. And yeah, you can see the panelists. I introduced them to you. We don't see you, but it would be great to have a bit of a view who we have in the audience. So we will have a quick poll just to get a bit understanding of the background of each of you. So please let us know. Are you a policymaker? Are you from the pharma industry, payer industry, patients, a healthcare provider, healthcare professionals? Just let us know. Voting. I will just quickly share with you to give an impression. We do have quite a mix of people. Unfortunately, not enough patients and no payers joining us today. That's a bit of a pity. But for the rest, we have a lot of different stakeholders, healthcare professionals, healthcare providers, pharma, and policymakers. So I think it's a great mix to have a discussion. And hopefully this means that payer says no, that nobody wants to identify himself, but hopefully there is some payers in the discussion. So thanks for this. Let's get started. I think, Gerard, I want to hand over to you. And in the first 15 minutes, let's present your view on the learnings on value-based healthcare today.
Thank you, Casper. So, and welcome again to all participants. In the first 15 minutes, I will take you through, let's say, what we've learned from value-based healthcare today. And thereafter, we will have a panelist reflection on that. And to start with the challenge that lies ahead of us. So there is a lot of things happening already in the healthcare system. We can already sense that today, and that those challenges will only increase going forward. So we have on the one side a challenge on the demand side of healthcare and on the supply side, and how these two come together. So we have basically a challenge there, and we see on one hand that the demand for care is increasing due to aging population, more chronic diseases, but also more different treatment options. And there is also let's say strong differences in the information position that patients have, so they are not equally informed, which stands in the way of transparency and accessibility of care. On the other hand, you see that people that need to deliver care going forward because of this increasing demand, and on the other hand, a reducing working population in the established markets, that for example in the Netherlands, that going forward 1 out of 4 people needs to be working in healthcare if you would stay the same, so if you would not change the way we deliver care. Also, let's say you see still the classic functions with their own data and financing, so the silos in both delivery and the budgeting, and also a limited overview of quality and efficiency and outcomes. So a lot of things that are hampering proper connection between demand and supply of healthcare, which will only increase going forward, mainly also due to the increase in elderly population. So the question today is that we, and as part of this webinar, is value-based healthcare. What is your answer to this? So to quickly take you through what value-based healthcare is about in the first place, I show you the model that we developed in 2017 based on the book of Michael Porter and Elizabeth Theisberg, Redefining Healthcare, which is the foundation of value-based healthcare. And we translated that view into the model that you see here on screen, where we said value-based healthcare is basically a change along 2 axes. One is about outcomes measurement and steering towards patient-relevant outcome. The other axis is more about integration of care and more transparency in care. And this all needs to be made possible by some critical enablers that also Michael Porter mentions in this book, is like IT infrastructure to support the transparency and outcome measurement, but also integral budgeting of care to be able to reward systems that are delivering relevant patient outcomes. What Porter didn't mention was, and that's what we added to the equation, is the 4th element of change management, to get from the current state of, in a lot of systems, still volume on single separate interventions, to a system where you have integrated care rewarded for patient outcomes. And then to get there, you need a lot of leadership and change management. And if you look at that model, basically you can distinguish between 2 main approaches, and I come back to that in a minute. You have this, let's say, more medical-driven scientific approach where you focus on outcomes measurement, whereas the other main movement is more a logistic, practical approach. Let's create more transparency and interconnection between the different care providers and exchange of data there without measuring, let's say, the outcome. Yeah, and in the combination, you have value-based healthcare at large. And this model we used basically to do a 7 case study that you can find in our latest publication, which gave us 10 lessons learned. And for the sake of time, I'm not covering all 10 of them, but just to highlight 4 of them. What we saw is that translating outcomes insights into improvement actions is not always easy. For example, the underlying correlations between, let's say, a medical intervention and patient-relevant outcome is not always clear. And we see also there that integration of care appears to lead to faster results for the reason that there's fewer errors, lesser under and over treatment, increased transparency, better cooperation between care providers. What we also saw that there is still a direct link with reimbursement is often missing. So we are still paying for volume, but care providers themselves are moving to care integration and outcomes measurement, but are not reimbursed for that yet, right? So the systems are not totally moved in that direction. And also there you see that silos in the budget stand in the way of innovation and scalability. Interesting for you to know is that the two of the cases that we were part of our case study, so Punt for Parkinson and Novartis, that are currently today in our panel. So Teus and Janneke will probably reflect on what they did with value-based healthcare. There is also one important overarching lesson learned, and that is that value-based healthcare, how great all these principles are, you cannot apply it to the full extent everywhere. So it's not one story fits all. However, applying a subset of the principles or the mindset that's needed for value-based healthcare, you can apply everywhere, but really going to the full extent, as Porter has described it together with Elizabeth in his book, is not applicable everywhere. And let me take you quickly through what we mean there. So what are the guiding principles for applying value-based healthcare? Basically, what is the sense and the nonsense of it? And let me start with the first axis, so the outcomes measurement. You see there that outcome-based control is not suited for every medical condition because it can become quite difficult in case of a very heterogeneous patient group, for example, or when the patient has a lot of comorbidities. So because at the end of the day, these different diseases add up to an ultimate patient outcome. So how do you distinguish between the different interventions and the impact that the disease has on different diseases have on the quality of life of patients? Also, small volume will not help you to get relevant statistical outcome, or if there are so many factors influencing the outcome, some of them sometimes, or in many cases, the patient behavior is also a huge factor. It starts to become difficult to measure and control the patient outcome. I also mentioned that if correlations are unclear, you can measure, but you cannot steer. Or if you cannot measure the outcome in an ambiguous way, and if there's a lot of variation in the measurement, or when the measurement is only manifesting itself in the long term, for example, survival, how can you control care today if I only have the outcome 5 years from now? And also if the degree of innovation is very high, then you see that what is good and the standard of care is constantly changing. So the benchmark of good care is shifting all the time, and then it's very hard to control care according to an ever changing target that you are aiming for as a care provider. So these are some elements that are well, not making outcomes measurement easy. Then the other element is that you need to be conscious of is that the moment that you decide to go for outcomes-based control, that you need to measure not only the outcomes themselves, but also the process parameters and the medical indicators in order to be able to correlate them with it and steer towards the relevant patient outcome. And therefore, you also need to understand the correlations between those parameters. And we have seen cases where people were measuring outcome, they saw the variations, but they didn't know where the variation was coming from. Well, then you measure, but you're still not improving the care delivery. What we also learned, and I come to that in a minute also, is that the way the care is organized, so in a line setup around a single disease, that is best fit for value-based healthcare at large, because you can integrate care and it's easier to measure all the parameters and also understand the correlations, because you have a single kind of standardized care pathway for around a single disease. Then coming to the other element of care integration, there it's largely dependent on the patient group and, let's say, how the care is delivered, how many disciplines are involved. So if the patient group is homogeneous and it's only one discipline involved, then basically you could talk about a routine intervention, a standard single intervention that doesn't require integration because it's just standing in its own right. If it's multidisciplinary and it's a very standardized patient group, then you can move to the line model I just referred to. But if the patient group becomes heterogeneous and you have only monodisciplinary intervention, then you need an agile model. I think the GP is the best example of that. It's a care provider that is adapting to the specific need of the patient. So that's the agile model. And then quite interesting, I come to that further in a minute with regard to the elderly population. If you have a heterogeneous patient group with a lot of disciplines, and you see that, by the way, also in the Punt for Parkinson, then care is delivered in a network, in a job shop model, because there is no single standardized patient care pathway because of the heterogeneous patient population. And a better form of a job shop model is a hub and spoke model, where you start to coordinate care. So let me explain quickly here the applicability of value-based healthcare per care delivery model. I already explained that for the line model, you can easily integrate into an integrated practice unit, like Porter has described in his book, and it's much easier to do outcomes-based control. With a routine model, well, there's basically no need for integration because it stands in its own right, but it could make sense to do outcomes-based control because it's a standardized procedure. But in a job shop model, and you see a lot of cases in reality that care is delivered in a more organic job shop model setting, there's rather low suitability for value-based healthcare because there is no single track, so it's rather coordination of care instead of integration. And outcomes-based control is very complex because what is the standard? What are the correlations? Each patient is different. Which brings me to an improved version of the job shop model is basically that you, in a multidisciplinary setting with a heterogeneous patient group, you should basically coordinate care and not integrate care. And then you move to a hub and spoke model where you add a central coordination point, which makes it on one hand easier to coordinate care and tailor the care delivery to the patient demand, and also understand better what is relevant for the patient and also coordinate the care delivery from that perspective. So you are basically both managing the supply and the demand side of care in this, let's say, more complex healthcare setting. Because here you simply cannot integrate care as Porter has described it, and also, let's say, straightforward outcomes measurement and then a learning cycle is much more complex in a setting like this. And in a lot of cases where you have comorbidities and a heterogeneous patient population, you end up in a care delivery model like this. So this is my first part, and I want to open the floor for the expert panel.
Yeah, so thanks, Gerard. I think for me it was a clear presentation, and just reflecting on it, I hope we didn't scare people away from value-based healthcare, because sometimes it looks like a holy grail, but I think the key message mainly is like, guys, it can solve a lot, but it's not just one size fits all. And I think you need maybe Teus to start with you, especially you have that really heterogeneous patient group, and as Gerard already alluded to, and the point for Parkinson, you really need to deal with it. So how do you define value for that group, the group you're working with? Can you help us out a bit there?
Yes, it took us several years to create a model based on that, because perhaps for those who are not very familiar with Parkinson's disease, this is a really very complex disorder implicating almost every part of the body. Everybody knows the elderly people who are trembling, but that's just a very, very small part, and actually it's extending from very young 20s people in the 20s up to, of course, every age beyond. And it's not only a motor disorder. That's the point, because people always think they walk a bit poor, but it's about cognition, it's about mood, it's about anxiety, it's about swallowing, it's about gastrointestinal motility, it's about the cognition, or what I said. So these are a very multi-disorder problem. So that was the disease. So we have we can think of multiple outcomes in terms of medical outcomes. You can measure the cognition and you can measure everything. And what we did actually a couple of years ago, we had the national setup of what we called Parkinson Insight, which was a national quality database. And every learning curve has to start anywhere. And this was a questionnaire which included quality of life. This included all kinds of cognitive and motor measurements, etc., etc. Overall, 130 questions. And we were able to keep that on for 2 years. And then it broke down because it was clear that the patients had to do quite a lot of formula fillings. And at the end, they were fed up with it. And so we had actually 20,000 records, which was quite a significant database already. But the interest and the enthusiasm from the patient side tremendously dropped after 2 years. And then we had to conclude this is not a sustainable thing on the long term. And then we went back, completely start at the beginning. And very simple, actually, we should have done that before. We just organized a meeting with a focus panel from our own patient group, trying to be that to make it as representative as possible. And we started very simply, what is important for you? So going back from all the disease parameters, but we went back to the patient and actually just asked them, what is important for you? What do we have to realize here? What does your visit to our clinic, what does it have to create in terms of results? And then actually it was a very nice evening because the simplicity came back. Because they mentioned very simple things. They said, we want to be able to walk as long as possible. We want to stay as long as possible independent. We want to visit doctors as less as possible. And we don't like to be admitted in the hospital. So these were very clear things. And as you can hear, because these are the values we are talking about. So independence, which is related to cognition, motor abilities, which is directly related to all kinds of motor scores, admission in a hospital and doctor visits, very simply to rate. And that's what we were starting at that point, and that's what we are now doing actually. So our prompts are very simply in our medical records. We have created a special Parkinson record, but also related to that a monitoring tool which is sent out to all our patients every 3 months, where we get an update to judge if they have to come to our hospital, because that creates a lot of burden for them. They have to organize taxis and family members to drive them, etc. So we have become very critical on this part, and all of these prompts are actually represent a direct value for them, because it's based on their own definition of what is a real prom and value for them. But they can be easily translated to money, because at the end we have to relate this to money. And as I said, this is quite easy to do. And one of our most powerful ones is, if you talk about independency, then staying at home as long as possible. That's a very clear value, which is translated in our center directly to money, because we were able with our model to postpone definite nursing home admission with 3 years versus a control group who didn't have this type of care, which is translated in terms of money. It's about 300,000 euro per patient. You can do quite a lot of things for 300,000 euro.
Yeah, it's amazing. Thijs, if I hear you, like what I take away a lot is, luckily I heard the word easy a lot of times, and I think it's also, as you said, it's like, and it sounds sometimes easier, just ask the patients, but I think we tend to forget to do that. And if you ask them, you get like very solid answers, and make it easy for them to provide you the information, I think, as well. And especially I like the idea that you were able to link it back to value also in economic terms, because a lot of times the value is only focused on outcomes, but the cost element shouldn't be forgotten, I think.
No, exactly, because at the end, and that's the nice thing, we have set this up, and I make a simple story out of it, but it took us several years actually to realize that the whole value-based healthcare should start with the patient. And that seems to be a very open, logical remark which shouldn't be made. But actually, if you look at all the models, they are quite complex, and so you should start with the patients. That was actually our turning point when we went back to just asking the patients, what is important for you? As simple as that.
And one thing to add, you mentioned the outcomes measurement, but you are only able to improve the outcome by installing the central coordination point, right? You didn't mention that. You totally re-engineered.
Yeah, no, that's a good point. There are so many things to tell about, but that's a very good point. Thanks.
Maybe can we address that later on? Because I also want to hear indeed a bit from Eva and Janneke.
Okay.
Is that okay for you, Teus? Yeah, we have to be a bit mindful. Good point.
I will reflect on that later, indeed.
Yes, it's fine. Okay.
Yeah, so Eva, I was really indeed, it's also from an oncology perspective, but if you put that, like what Gerard presented on what's how value-based healthcare is being conducted today, what's your key take? What did you take away from that through the lens of oncology patients or cancer patients, actually?
So just to kind of build on what was just mentioned, you know, as a patient advocacy group, we're actually at the forefront of pushing that movement to always hear the patient voice and actually take the time to ask patients what they want and not assume, like we have historically done in the healthcare system, that doctors already know what patients want and need. And so by actually asking patients what they need, having those focus groups and having them inform, instead of collecting all the thousands of prompts that we can collect, why don't we collect the 5 that matter most to patients for that defined patient segment? And I think that, you know, to go back to Gerard's presentation, oncology, when you bring it down to a very clearly defined patient segment based on shared needs, you can have a line model. But we'll talk later about how, you know, that can be applied to managed care when you're looking at, you know, the consequences of you know, having an acute condition becoming chronic, you know. So we'll talk about that later. But one thing that stood out to me the most out of your book and your presentation is the importance of change management. So you mentioned that in the Porter Teisberg, you know, initial book in 2006, it wasn't mentioned, but in the graduate course at the Value Institute in Austin, led by Professor Teisberg, we do actually touch upon the importance of change management, the importance of good communication, effective teams that share data, but also engaging the key stakeholders. And in Canada and what we're doing in oncology, that's a key part of our strategy, is engaging the key stakeholders, including patient partners, including the people responsible for implementing the VBHC change. So not just, you know, having it come from the top down, but actually including the people that are responsible for implementing it, because otherwise it won't succeed. And also, and I think that this varies according to context, but in our case, including government or key decision makers, you know, that will actually be necessary to scale up this VBHC vision, and that are necessary to actually implement the structural enablers like IT infrastructure and actually tying those outcomes to reimbursement, which is also essential. So I think that change management approach hasn't been discussed enough at the conceptual level of VBHC, but now as we start looking at different case studies, we notice that, for example, you know, measuring just to measure is not sufficient to improve outcomes. You really need to engage all the key stakeholders and look at that care integration. And so one of the big highlights and takeaways for me from your book is actually the importance of prioritizing care integration over outcomes measurement, because care integration leads to outcomes improvement as well, but not vice versa. So that was a really key point, and I'll stop there because I know we have so much to talk about.
Thank you.
I don't know, Gerard, you want to shortly reflect on that?
No, I think let's, for the sake of time, give Janneke time to give.
No, we are okay on time. And just my main reflection, I really liked it because just a quick one on you, Eva, because I think it sounds also there, it sounds easy and obvious, also the change management part, but I think the people need to start realizing the value-based healthcare is a neat combination of top-down and bottom-up, because I think that's also where the language is usually a lot next to each other, because some people talk value-based healthcare in a hospital and they're implementing in their hospital, but that doesn't go without value-based healthcare at the system level to also facilitate the conditions indeed to make it happen. And you need both also to scale up. And I think a lot of misunderstanding in the field is because people just simply talk at the two different levels and ignore the importance of the other one. So no, really fully on board there. Yeah, Janneke, yeah, maybe indeed that's really interesting, because I know also from a pharmaceutical company perspective, and you personally, you also have a quite strong vision on what value constitutes. And I think you, Teus already gave it from the perspective of the patients with Parkinson's disease, but how do you see the definition of value? One of the most easy but most complex words as well, I think. So curious to hear that.
No, thank you, Casper, for the question. And of course, I totally agree with Teus that patient value is a extremely important factor that we need to take into account to determine the overall value of an intervention. But to me, there are three other factors as well that we use when we talk about, what is the value of an intervention? Could be a medicine, could be something else. So the first one is indeed patient value, right? What matters to the patient? What outcomes matter to the patient? The second one is clinical value, and they may not always be the same thing. So clinical value often is measured with very specific efficacy and safety measures, while patient value might be something like fatigue that is maybe not always included in the pure clinical measures. So patient value, clinical value, healthcare system value, which is, for example, if a medicine, let's say for heart failure, can reduce hospital admissions, that has a value to the healthcare system. So there's a cost reduction there. And then the fourth element of value that we think should be taken into account is what we call societal value. So this, for example, includes a loss of work, right? So if a patient has a disease, that means that they have to miss days, work days. That, of course, has an impact on society, on tax, etc. So that is how I would define the value of an intervention with these four measures.
And that sounds to me, at least, and I think hopefully for everybody, quite holistic. And that then also means, if you describe it this way, there's value for everybody. So then where you think, I would think at least, if it's so obvious and so clear and so much to gain, why are we not delivering it all the time? So in your view, what's then standing in the way of getting there? Yeah,
no, great question. Actually, there's quite a lot standing in the way, I think. Maybe one technical point and then a more holistic point. The technical point, I suppose, is on the societal value. I mean, this is the value that actually today doesn't really get taken into account when the value of an intervention is measured in many cases, because the budget is siloed, right? The benefit of a patient maybe being able to work again or work more sits somewhere else. It doesn't sit with the health minister, but sits with the finance minister or somewhere else. So often that value is actually missing from the overall evaluation, which I think is a shame. But maybe more holistically, what I think is one of the big challenges and also opportunities in many of our healthcare systems is a bit similar to what Koen described before with the supply and demand equation that you had, where actually in many diseases, a lot of deaths and a lot of morbidity, a lot of suffering could already be prevented if we only apply properly what is already available to us. So of course we need more research and innovation to tackle diseases that are still untackleable today, as many aspects of Parkinson's and Alzheimer's, for example. But if you look at cardiovascular disease, 3/4 of the deaths today of what is the biggest killer worldwide, right, cardiovascular disease, 3/4 of the deaths could be prevented if we would be able to bring together all these patients out there that need interventions with what is already available today in the system. So there are many bottlenecks. It's a bit like a train where you actually have a lot of seats in the train. You have all these patients in the platform, but when the door opens, it takes a lot of time for everybody to get out and other people to get in again. to reach that capacity. So in the healthcare system, at least from an intervention perspective, different therapeutics, different medicines, in cardiovascular disease, if we would manage to get all these patients out there to everything that's already available today, we would prevent 3/4 of the current number of deaths. So that is enormous. And this is where, it's complex, of course, to remove those bottlenecks. But I think this is where we all need to work together, all the different stakeholders, pharmaceutical companies, healthcare providers, payers, patients, everybody needs to work together to remove those bottlenecks so that we can have a significantly more impact on patients' lives.
Thanks. Yeah, that's already almost in my mind. It's the call to action that I wanted to ask you at the end of this webinar, but I think this is a great one. And I think it's especially also because for me, it also resonates at the silos. We see them every day. And I think, Teus, that's also what you with Parkinson's patients also see. Silos, not coordinated. And again, there, and hopefully maybe Gerard, you can shed a bit of light in how we can take that coordination to practice, because the coordination element comes through all stories. So maybe if in your view, if we look forward, is how do you see that? And can you bring that to the next step?
Let's say Parkinson's to that extent is a very nice model because it's so complex. And to give you an idea, around 20 different professionals are concentrated around one patient with Parkinson's.
Yeah.
It can vary a bit. Some have 10, others have 20, but 20 different healthcare professionals, partly being in the primary line of care, a lot in the secondary, but also in tertiary, etc. So all these people sent their bills to the payers. And when we started with Parkinson's, it was only known what the overall budget was and the overall costs were, which were increasing, and for no known reasons, because it was a very complex issue. Of course, the numbers increase, as we know. It's the fastest growing brain disease of this moment, together with Alzheimer's. And Parkinson's even grow faster, but also the cost per patients were increased, and so at that point we started to split up the costs in much more detail, which was the start of a dashboard together with Mensis, which was our primary partner from the payer side. And so what we realized is, and that's what we also told Mensis, we think we have to organize it in a hub and spoke model with a central organization, a central which we called Point for Parkinson's, which should take on board the coordination of the whole chain, which is still ongoing because that's a long and lengthy process. But at least with one central point where you try to connect to all the other 19 stakeholders actually in the care process of a patient. And then we realized we need a very advanced ICT system, which was not paid for by anyone. And so we tried to look for a real platform which could couple all these information streams from nursing homes, from paramedics, from medical specialists, from etc. General physicians, not to forget, pharmacists. And that's where we are now building the story. We are now working with Philips actually to use their Engage platform as a central platform which really can communicate about patients, and not only as a information as a block of information, but really to share information with a central dossier where people can put in information and where people can get out information. And so that's actually the model we are now building, starting with general physicians, with pharmacists, and with paramedics, where we collaborate with the Parkinson Net team from Bas Bloem from Nijmegen. So that's actually the way we approach it. And the simple philosophy here is it should be done. So we have to determine which complaints have to be addressed by which professional. So you need guidelines, and that's where we started for a couple of years ago, writing the guidelines. What do we have to do, and who is the primary responsible person? And then, of course, you have to organize it. So we have now several nurses who do this coordination together with the monitoring tool, which gives them a daily flagboard where they can see which patients might be in trouble, and these get the first care, and then it is determined who will provide the care.
Yeah, thanks. And I think you already addressed quite a bit of what we want to discuss in the second section, but thanks for that, Teus. Yeah, and then Gerard, maybe as a bridge, can you take over and bring us back to the future, and then we go back to the panel for the reflections there? And,
yeah, and I will speed up a little. I'm being conscious that we have time. So looking forward, so we shared with you the principles of value-based healthcare, and when does it apply and when does it not apply? So to take a conscious decision, and also what can help you in that decision, looking at the applicability of outcomes measurement versus how the care is organized, whether it should integrate or coordinate, and whether it's integration or coordination that leads to faster results or measurements or both. And now quickly want to look forward and say, okay, what does this all tell us looking forward? And I want to start with the notion that we have an ever increasing elderly population. And there immediately, of course, you see that this population is comorbid, heterogenic, and therefore not really fit for pure value-based healthcare. You see the graph on the right that comorbidities rise with age. So that means that there is no single unambiguous care process, first and for all. So they're all in a network with multiple diseases. So Parkinson itself is already, let's say, multifactorial, multidisciplinary, but on top of that, elderly patients can have other diseases like diabetes or require orthopedic surgery or whatever, right? And these all need to add up to relevant patient quality of life. So if you look then also to the standards that are set by ICHOM and the Institute for Outcomes Measurement, they defined the standard set for older persons, but there what you see are holistic outcomes that are not linked to a specific intervention, so only holistic outcomes. So it's very hard to relate them to the interventions that are being made in this, let's say, organic patient journey, which means that we are wasting scarce resources, because a lot of people with multiple diseases, chronic diseases, and elderly patients, they are in a job shop model without coordination, which leads to undertreatment, overtreatment, miscommunication, and errors. And therefore, it's a very inefficient system that we can no longer afford, especially with this growing elder population, and also combined with COVID. You see there that COVID is bringing an additional complexity and putting more stress on the system. And some people say infectious diseases are here to stay. So we really need to be very effective with our scarce healthcare resources and the way we deliver care. So if we cannot integrate, we must coordinate. And moving from an organic job shop care delivery model to a coordinated hub and spoke model. And there were some questions already I saw, how do you need to do that? And I come to that in the final section before the Q&A, directly after the second panel discussion, what is needed for that. So the point here is that you proactively manage care delivery towards patient-relevant outcome. Like Teus said, you need to understand what is relevant for the patient, and then you steer the patient to the right medical professional or care provider. So instead of measuring in retrospection. So it's a virtual practice network instead of an integrated practice unit, and therefore value-managed healthcare instead of value-based healthcare. So value-based healthcare applies the principles of value-based healthcare, but you cannot apply them in a very mechanic and in a theoretical way as it has been described. Well, if you do this for one disease, the ultimate solution is then that you do that for multiple diseases. So you could have, let's say, Punt for Parkinson that Teus is running at the moment around Parkinson disease, but this older person also might need a hip replacement that is organized according to the line model. And to get to best outcome, you need to understand what is relevant for the patient and how you coordinate this patient towards relevant care, and also keep track of what is happening to this patient so that they don't fall between the cracks. Because now we are basically depending on the patient that and with his direct relatives or family, that they are able to have the oversight and come to the right decisions. But that's not the case, especially if you're very sick, right? So in elderly care, significant value can be created with value-managed healthcare, and I think Punt for Parkinson is a clear example of that. So you can clearly see the savings that you can make, but the problem there is that the reimbursement system is not rewarding that because of the silos. So that is something we need to solve also, that we look holistically at care and that we integrate care and use the right IT systems there to support it, of course. So a lot of things still to be done, and we need to do this together. So it's about making the invisible visible through proper coordination of care and steer towards relevant patient-agreed outcomes, putting the patient centric. Then the second point is how to apply value-based healthcare within an increasing outcomes-driven pharma industry, right? They are more and more need to show the evidence of their efficacy, and people want to understand what the pharma companies bring. And I think Janneke clearly outlined there's a lot of value that pharma can bring, but we need to make it transparent. And it brings us to the point, to what extent can pharma take responsibility for patient-relevant outcome, which is not a straightforward thing. Because if you look at the pharmaceutical intervention, which is in a way a routine intervention, because it's a very standardized, clearly defined intervention for a very targeted patient group, very well described as part of the label. The question is, how can pharma take final accountability for the patient outcome in this complex care setting, because there are so many factors at play here. So we gave that some thought, and there is, let's say, the most simple situation would be that pharma is the only preventive or therapeutic intervention. And there are not a lot of examples there, but there are a few examples, for example, in hematology, that pharma is indeed the only intervention. Well, then it's very easy, of course, to say, okay, we take responsibility and accountability for the patient outcome, although there are more factors coming to play there, but I will show in a minute. Then in a more complex setting, then it becomes, of course, also more complex to take accountability for outcomes and control them as a pharma company. So it could be that the pharma intervention is taking place within a controlled, integrated care pathway in a line model. Well, there, since it's such a, let's say, care delivery under clear conditions, there is a possibility, of course, in cooperation with other care providers, that pharma takes co-accountability for the patient outcome. Or, and that's an easier situation, that pharma is at the end of a complex care pathway, where you say, okay, I now will take care of the patient to maintain his status, secondary prevention, for example, where you say, okay, I understand the patient's status, and I will take responsibility as pharma to optimally maintain the quality of life of this patient and take accountability for it. But here, it's very important also here, it's not one story fits all. For pharma, you need to look, where do I intervene? and where can I take accountability for the outcome. So there are some additional conditions. So once you decide it makes sense to measure these outcomes, there are a few extra things, extra conditions that come into play. For example, the first one is that you need, in a complex setting, cross-disciplinary collaboration and ownership regarding the patient outcomes, because pharma is not the only intervention. You need to be very clear how you partner up with other care providers and sometimes payers also, to say, okay, what is our joint responsibility and how does this translate then to individual responsibilities? Secondly, you need to have insight in the care process from intake to aftercare to be really sure what is the patient mix, where do I intervene, and you need to have insight in the total care process and be able to measure, let's say, the different parameters. There should also be, of course, a clear understanding how pharma is influencing the patient outcome, which is also not always a direct correlation. So you need to sometimes invest in a better understanding of how the pharma intervention is influencing the patient outcome. And lastly, it has been mentioned before, you need to have integrated infrastructure for data registration, processing, and data access, of course, to understand what you are doing as a pharma company and to take accountability there. So there's a lot of things that come into play, and sometimes it's better to say, okay, I'm not taking responsibility for the patient outcome as pharma, but I'm taking responsibility for an interim result, which is of course suboptimal. But as an alternative, pharma could consider a surrogate outcome. So that's an outcome of which you know that it has a huge correlation with patient relevant outcomes. So it's an interim kind of measurement, or the more simple binary, let's say, patient response, non-response measurement. So is the patient indeed reacting to the pharmaceutical therapy? Then lastly, what is I want to bring to the table is that for pharma, value-based healthcare triggers also an important strategic choice and also a definition of the role that they want to play in the healthcare system. So it is first of all in the area of outcomes measurement. Do I want to measure a real patient outcome? Do I go all the way? I'm the only intervention? Am I in a controlled setting, or am I in a complex setting? And is that not possible for me? Should I go for a surrogate outcome? And to what extent do I want to set outcomes standards around this specific treatment, and maybe even define a standardized data set for that is then filed at ICHL. Yeah? So what is the role you want to play? And also, how does it link to the company that I want to be in the healthcare system? Linked to that even more is the improving and integrating of care. So am I there to co-develop care optimization solutions? So there you move from, let's say, product supplier to, let's say, healthcare partner with your other healthcare stakeholders. So do I play a role in improving care? Do I want to be a constant partner in continuous care improvement? Or do I even go a step further where I develop or acquire disease management services? So I'm moving forward even in delivering certain care solutions in the whole healthcare ecosystem. So that's quite some conscious choices that a pharma company has to make, that has a direct link with the company strategy and the role that you want to have in the healthcare system. And then lastly, I think an important notion is that pharma also has another way of putting the patient at the center beyond value-based healthcare. So to what extent do you move to patient lifecycle management instead of product lifecycle management? So do I take the full patient cycle into scope, including maybe prevention, aftercare? So how broad is my role looking at the total patient care pathway, the patient life cycle? And also, I think there's a direct impact that pharma can make is by patient co-creation along the product life cycle, by involving patients already when new pharmaceutical products are developed. So have a more patient engagement in the R&D process. So I think there are different dimensions that the pharma company can play to put the patient at the center. Which brings me to the second expert panel discussion. Casper.
Yeah, sorry, thanks, Gerard. I was on mute. It's the classical error, and yeah, we have to move to Janneke first. You were addressing the pharmaceutical sector and talking about taking accountability. I think Novartis is one of the companies that wants to take accountability, and as you said, it's collaboration then is key to make that happen for a pharmaceutical company. And I'm wondering that for me that brings it to partnerships, etc. Janneke, do you have an example where Novartis was able to establish a solid partnership to really drive this?
Yeah, absolutely. And thanks for asking the question. I can't answer probably on all the questions that were on Gerard's slides because there was a lot of invitations for pharma, but maybe specifically on this one, absolutely. I'll mention a very concrete example in cardiovascular disease that you may have seen in the press recently, where we wanted to address these bottlenecks that I just talked about, right? We know, like I said before, in cardiovascular disease, a lot of innovations already available, a lot of patients out there, but getting them together is challenging. And maybe specifically now focusing on secondary prevention, so patients who have already had a cardiovascular event like a heart attack or a stroke. I mean, those patients are at very high unmet medical needs, but still we see the same problem, that they're somewhere lost in the system and not getting to the interventions they need. And actually I saw a question as well in the Q&A from Eduardo Pisani around this, what are these bottlenecks that I mentioned before? I mean, one is patients are lost in the system, so how can we partner to identify them again? And another one is sometimes administrative hurdles that get in the way of bringing the right innovation in an easy way to the right patient. So an example of where we partnered to address these bottlenecks is actually very recently with the NHS in England, where the NHS recognized as well as we all do that cardiovascular disease is their #1 killer. And they wanted to bring all these interventions, these innovations together with all these patients, especially those patients at high risk that have already had a cardiovascular event. We have the same mission, right? We would love to bring our innovation faster to those patients in need. So we started to discuss how we can actually work together to open the door of the train, right? To remove those bottlenecks. And we came to a collaboration where we have now an aligned objective. We want to treat 300,000 patients with the most innovative medication to, in this case, it was about specifically lowering their cholesterol. That would lead to 30,000 lives saved and 55,000 heart attacks and strokes prevented. And we do that together. So the NHS is deploying their capabilities. We are deploying our capabilities to remove those bottlenecks. So for example, the patient identification, which is one of the major hurdles, where are these guys? The NHS can do that. They have deployed an algorithm on their system to find those patients that have already had a heart attack and a stroke, bring them in, make sure the incentives are in place for the primary care physicians to deploy the innovation, and make sure the outcomes are measured, the patients are followed up, etc. So I think, it is possible to open the doors, to remove the bottlenecks, but it is indeed, I think, as Gerard said before, pretty complex and not something that one company or one system or one stakeholder can do alone. You need to partner, bundle the expertise, our research expertise and education expertise with the NHS digital expertise, the logistics, the incentive systems to come together. And only in that way, I think, can we have a really significant impact on improving healthcare and, making sure the value gets to the patients in need, and we do achieve those outcomes that are basically out there up for grabs, right? The patients are there, the interventions are there. We just need to figure out how to bring them together in a more efficient way. So it is possible. We're proving that as we speak in England. And we are very keen to actually have similar partnerships in other countries, because indeed the frustration, I think, for us and for many systems is high that these two are otherwise not getting together. So very open to more of these collaborations.
I think hopefully a lot of people will accept that invitation. And I was just thinking one thing, Janneke, what you mentioned here about that the collaboration indeed is key, but it also, I think, requires that people start with a bit more open mindset about the other stakeholders in the system, because what you said, NHS helping in identifying patients, a basic attitude could used to be, ooh, then we get more patients in the system and then it becomes more expensive. Well, I think that's the classical thinking. So it also starts with entering this domain together with a more open mind about some attitudes.
Well, I totally agree. It all starts with being transparent from all sides on, you know, what's in it for the NHS, what's in it for us, be transparent. Because indeed, otherwise there will always be this mistrust. And again, yes, happy to be totally open also about what's in it for us. Yeah.
Thanks a lot. And yeah, and I think cardiovascular disease is absolutely probably one of the biggest killers, but there's another one called cancer. So Eva, I'm also wondering how you reflect on this and from your experience, and also linking a bit, probably maybe even also to pharma. I'm also wondering, because if you talk oncology and pharma, you get to precision medicine. And I think, yeah, talking complexity, how do you fit that into value-based healthcare? Do you have any ideas on that, or any views or help, suggestions to all of us?
Yes, for sure. So but precision medicine and precision oncology, it presents very specific challenges, because in terms of outcomes, precision oncology promises to deliver better outcomes with less side effects, but it's more expensive. And so currently we're making decisions based on cost and not value. And so with the vision of value-based healthcare, we can actually, we can encourage the system to actually adopt this vision of measuring both costs and outcomes, and to make decisions based on value, which would actually promote the use of precision medicine. Because right now in oncology, we're using precision medicine as third, fourth line. If the patient is still alive after the first 4 treatments that haven't worked, then maybe we'll spend the money to do the precision diagnostics, and then maybe they'll still be alive to get the precision therapeutics. But if we had this system where we would actually measure how much it costs to hospitalize that person, or how much it costs to do 3 lines of treatments that don't work, then we can actually invest in the value, which is to give the right treatment to the right patient at the right time. And so I think that's how it relates. And also yesterday, I was participating in a panel on outcome-based agreements and real-world evidence. And so again, I think that there's an opportunity to tie the outcomes that matter, so both clinical outcomes, but also patient-reported outcomes, to reimbursement. We should actually be investing in what works to make our population better, not just in health services, but in actual health. So I think that in that perspective, it really will help to shape this cultural change that we're trying to promote with value-based care. And then if I could just go back to the
yes, you can.
Initial part, I think you had a I'll just tie into that right away. And if we want to go back to what Gerard presented in terms of the managed value managed healthcare. And I think that that's very pertinent to oncology, because currently we're looking at the line model for very distinct patient segments in oncology. For example, breast cancer, colorectal cancer, prostate cancer can each have their own integrated practice unit. And it's a very kind of discrete trajectory that we can standardize and collect outcomes as we go along. However, luckily, with all these innovative treatments that we're seeing lately, we're actually going from a purely curative approach to cancer, where it's very binary. Do you have cancer? Do you not have cancer? Where patients care a lot more about quality of life and not just, living longer, but living well. And so now we're actually looking at radically changing the way we approach this, when we see that cancer can actually be a chronic condition. So not just for, hematological cancers like chronic leukemias that are actually, people are luckily, they would die 20 years ago with CML, for example, and now people are living 20 years plus, and they're living pretty well. So how do we adapt our model? It's no longer a line model. And also we're having a lot more survivors, which is great, but there's also an incidence, a very high risk of relapse. There is a high risk of having other types of cancers, secondary cancer many years later. So how do we address this? I think that the model of having that hub and spoke, that kind of navigation of the healthcare system, and and actually ensuring a good quality of life within a longer horizon than only 1 year. So I think that VBHC in its pure form is really good for short timelines, 1 year, 2 years. Can you see immediate results in terms of overall survival? But we need to look at other clinical outcomes too. For example, like just progression-free survival might actually be the desired outcome and not a cure, you know, or living well with a chronic cancer or a chronic condition or the side effects. You know, how do we manage lymphedema after a cancer and make sure that that doesn't negatively impact that person? And so I think that hub and spoke model is going to be really interesting as we start to consider that, you know, and a lot of elderly people or older people have cancer as well. So there's this heterogeneity and this complexity which lends itself. So I think there could be a good combination. And I know that it's very context specific, but I know that in Canada, we have some jurisdictions have cancer agencies, or we have cancer centers where there's actually a care navigator that can help accompany the patient. And I think that that's a role where we can really use that value-based approach to ensure that patients get the best outcomes, and not just in that, you know, one trajectory that they're following for their cancer, but in other connected, you know, service areas.
Yeah, and what really resonates for me, indeed, as you say, like we need to be careful with, especially when patients live longer and disease-free. We need to be very careful in picking our outcomes, because in oncology, if you start measuring overall survival, how long do we want to wait to measure that? Is that 10 years? So you need to find more leading outcomes like progression-free survival. Thanks. Indeed, I totally believe as that as well, and I don't think we're that open-minded in most health systems. And I think you mentioned a really nice terminology, the Care Navigator, and I think it's a nice bridge also because I want to get some reflections from Teus, because I think Punt for Parkinson, in essence, is that Care Navigator. And you already talked a bit about it, but I want to maybe specifically, if that's okay for you, Teus, also you mentioned a bit for me on the sideline the role of Mensis, which is a health insurer, so a payer. How big is the role in the collaboration? How critical is that the payer is part of such an initiative?
Now, I think that's very critical, because at the end, it has to be paid. All the IDs need payment, and so the insurance companies have to be convinced on the new endpoint being value instead of volume. And that's exactly that's the hot issue. Because it has been proven in the last years that it is quite difficult for several diseases to make new, robust, value-based endpoints. And that's where the skepticism is about. So they know what they have. They have a volume system, and that's very clear. If you do more, mostly you get paid more. And to change from that system to value, yeah, we, as you know, we all know, we are talking about this for years, but they are a bit scary to change the system, because they are not sure that the value we are talking about is really not increasing the costs, which is a very significant problem for them. And so at the end, the real question is, does the society and does the payer want to pay for real added value? And that's sometimes the point, because we still have and we have a very good partnership with Mensa. So what we did, we started to make it to get a good insight in all the details of the costs. So we have now a dashboard for 5 years, which is completely filled with all the costs on every level. So we know exactly what the general physician takes, what the medical specialist takes, what the drugs takes, what the all kind of aids like rollators and wheelchairs, etc., what they cost. So we know exactly what it does. But then at the end, if we want to change to the value system, then it has to be not more expensive, or hopefully even cheaper. And we have to make clear very clear what will be the change of the system if we are focusing on value. So what is new, and what old system will disappear and what reimbursements will not be made. And then you are entering the complexity to do it for the whole era of professionals. In our cases, that's about 20 different societies with different professionals who all take care of their own income. And so who is willing to change to the new system? Because they all fear that they may lose income and are not able to make clear the new added value. So that's actually the transition problem as well. So still, although we have shown value for a simple case, in our case we have one of our endpoints is very hard endpoint. We delay definite nursing home admission with 3 years, which is a clear added value, which is clear quality, and which is clear reduction in costs. But what is now the problem? The payers are only interested in the costs made in the first to third line of care and not in nursing home care, which is a complete different silo in the Netherlands. And that needs that there is not only a new vision on an endpoint being the value added to a patient, but also to an integrated payer system where the overall costs are being considered and not only the costs in particular silos. That's a real big problem. That's actually the problem which still is one of the biggest hurdles in the implementation of our system.
And I think you make an interesting point there that I remember that I'm supporting a European value-based healthcare think tank, and I joined that 3 years ago. And one of the was a remark that value-based healthcare is like it's a win-win-win for everybody. But then I also realized, I made the comment there, and I think it's an important one to realize that on the short term, it might not be for certain stakeholders. There, as you say, there might be doctors on the short run who lose income, and you can't solve it directly always, but at least it starts with at least recognizing in all openness and transparency, Janneke, the word you also used. I think at least to recognize it and try to find the solution to bridge it. But I think it simply is not always a win-win-win. It's not that easy.
No. And what payers are very scared of is if you make a new value-based system, where we were talking about new drugs, for instance. Now we all know that the pricing of drugs has increased tremendously, and I feel the skepticism about the translation to value, because these are different ways of looking at what should a new drug development cost per patient per year, for instance, and that's still a difficult thing to make clear for all the stakeholders involved, because sometimes I get a feeling that they think all these nice societal impact and all these other impacts, which have a real value, but it's a way to create a value which is perhaps not the value in the eyes of the payers.
I think, I think we're running a bit out of time, but I do think this deserves a bit of a response from a pharmaceutical company, Teus, if you're okay. So Janneke, maybe you can see how this is, because
I try to be challenging.
Thanks for that. And I know Janneke likes to accept the challenge. So.
Absolutely. No, but I think you highlighted the challenges already very well, Teus, in terms of the silos that exist. So where maybe one payer pays for something, the value generated in reduction in hospital admissions or reduction in nursing homes, or as I mentioned before, the ability for people to work actually land somewhere else. So one party pays, another party gains, and that makes it difficult. And you also have the time horizon, right, which is often a challenge, where you have an intervention that costs something today, and the benefit you see in the next 4 or 5 years. And then, a health insurance company is afraid that maybe they're not actually reaping the benefit, but the next company that maybe the patient has switched to by that point in time, right? So I agree with you that capturing the total value for the system is something else than capturing value for individual parts of the system. But I still stand by what I said before, and I think you also agree from what I heard you say before, that any intervention, whether it's a medicine or something else, the price should be based on the outcome, on the value that it brings for the patient, for the clinician, for the healthcare system. And yes, my wish list, which is not the reality at this point in time, is that societal value of ability to work, for example, also gets taken into account. But today that's not the case, right? Today that is more a dream than a reality.
Now, I'm a little bit. Now I'm quite hopeful, and I will just mention one example, and that's a very simple example. Starting with a volume-based payment. That's every visit in a clinic or outpatient clinic is paid. That's part of the volume-based system. And we and others did the same. They checked how many of these visits were absolutely necessary at the moment where the appointment was made. And it will not astonish you, 1/3 was absolutely not necessary. And patients started with saying, "I'm completely happy, doctor. It's going very well. I'm very thankful for your new treatment, and the drugs are beautiful." So actually then 10 minutes is spent because of politeness, but nothing is added to the system. Whereas with if you try to add value, we now use a dashboard with red flags, which are coming from the monitoring system we have implemented. And now we try to create extra time on our outpatient clinic, which had a waiting list for 3 to 6 months, to at least avoid these unnecessary appointments and giving them to patients who are on our dashboard with a serious remark on one of their healthcare issues. And so that's a very simple way of turning from volume to value based healthcare, which creates money, is much cheaper, is much more efficient, and everybody is more happy. So I'm really a believer in the added value instead of the volume, because that's for a big part a useless system.
Okay, let's continue because we are running out of time. Terribly. I quickly want to, and we have a short poll for the audience also, how they look at value-based healthcare and what they think is the most important condition for success. And I think a holistic view in the system is important, and there are other things. So we are still curious from you to know. So I will do a quick wrap up of, let's say, what does this now all mean? A kind of quick summary. So where to go from here, basically, and I keep it very short. So we feel, and looking at all you saw the case studies that we did, and also looking at the different dynamics that you need to take into account for value-based healthcare. We said value-based healthcare you need to implement in a targeted way based on disease and patient characteristics. Whereas value-managed healthcare you can implement broadly because it applies to a huge patient population, comorbidities, chronic diseases, elderly patients. So there you can gain a lot with care coordination. And I think Teus is doing that in a very small, let's say, setting around one disease and having already a huge impact. Can you imagine if we do that for multiple diseases and then even across diseases? I think the impact we will have in terms of quality and costs will be tremendous, but we need to start doing that, of course. If you look at these benefits, you will have fewer errors. It would put lower burden on nursing and medical staff that is a scarce resource, because they're now not able to do their job because they have to handle disruptive issues in the whole supply of care. Well, you can easily move that to a coordination point so that you don't put that burden on the care provider. And also value managed healthcare organizes both the demand for care as well as the provision of care, whereas value-based healthcare is only looking at improving the provision of care. So value managed healthcare is also bringing demand and supply of care together. The question now arises, how do we do that? Who should be doing that? And we looked into 5 different scenarios, like the patient themselves with the informal caregiver. Should it be the GP? Should it be a major hospital, regional hospital or academic hospital? Should it be a trusted third party or a virtual artificial intelligence buddy? Well, the latter will for sure play a role in the future, but the technology is not that advanced yet that this technology can provide that coordination role. We already said the patient is not really having the capabilities and the overview to do it. And we came to the conclusion that ultimately it would be best to have an independent care coordinator, trusted third party, which then depends on your local system who that should be. For example, in the Netherlands, you can imagine that the payers that have so much insights in all the care that is delivered and also in quality and cost parameters, that they could play a coordination role if you put also proper governance on top of that. Bottom line, it's time to act, and let's implement value-based healthcare with focus. Let's implement value-managed healthcare broadly, and I would invite everybody of us to play a role there, because we need to do this together across all the stakeholders in the healthcare system. And with that, I skip my last slide and go to the final slide here. If you want to see the full report, these were just some highlights. You can download it for free on our website, or now making a picture of the QR code. And I want to move back now to some polling questions that Casper will do together with you.
Yeah, I think we will skip the polling questions and address some of the questions live, because we only have 5 minutes left, and I'd like to hear from some of our panelists because there were some really good questions to raise. So maybe Eva, quickly for you, it was asked to the panel, but I think it's really interesting to see on your side. If we talk into the care coordination, then already you made a big case of integrating in certain forms of oncology, but even if, and Janneke is advocating, have an holistic view on cardiovascular, but even above that, can we go one level higher, even, especially if you talk comorbid patients? How should we deal with them? Any view on that in 1 minute?
Absolutely. Well, yes, in 1 minute I can summarize.
Okay, 1 minute then.
We need data, and we need interoperable data. And we need the data to be transparent and shared. And right now, I know that in Europe, in Quebec, we just came out with new laws, managing like health data. And so I think that we need to, yes, ensure, the privacy and confidentiality of health data, but also using that health data to make informed healthcare decisions. And I think that the COVID pandemic has showed us how important, how essential it is to have up-to-date, actionable data to make better health care decisions, to make better decisions for the health of our population. Because ultimately, at the end of the day, what patients want is not more services. They don't want more health care services. They just want the health part. They just want to be healthy. And we can only do that if we have the right data, and if the right decision makers have it at the right time, not a month later, not a year later, but in real time. And so I think that in order to have that care coordination, yes, at the individual, and cancer is not one disease, it's actually multiple diseases. And so just managing multiple cancers is a challenge in itself. But yes, I do think that within a medium, time horizon, we can actually manage all health, as long as we have the cost outcomes, the clinical outcomes, the patient-reported outcomes, and the process metrics, which is basically what we've been measuring only up to now. But if we have all of that information in real time, then yes, I do think that we can manage care at a broader scale, have that, societal value be considered, give patients what they want in terms of you know, better health and not just services. And with our aging demographic globally, I don't think that, you know, doctors are going to lose out. I'm sure that they will have other patients to replace those that are healthy and that don't need their services. So I think that if we just continue to focus on that piece of data, interoperable data and real-time data that can be actionable and not just measuring to measure, then I think we'll get to where we want to go. Thank you.
Janneke, can I ask you a bit to reflect on the same part? I see you are, of course, advocating from your role to focus on cardiovascular, as I said, but is it for you also quite obvious that we also need to go even beyond and focus on the health state?
No, absolutely, and I don't want to only advocate for cardiovascular disease, of course. I think
no.
Very true for cancer as well, was just using cardiovascular as the opportunity is so big.
Yeah.
But I totally agree with what Eva said on, you know, the integrated data being the key facilitator, right, to bring coordinated care to patients. But in closing, I would indeed want to emphasize again on top of that, you know, there is so much more we can do today with what is already available. There's so much opportunity for all of us, I think, to partner on bringing patients in need the highest impact we can have on patients that already have a high risk. Could be already diagnosed cancer patients, could be cardiovascular patients that have had an event already. Let's partner to bring them together with what's already available today, because we can talk about value as we've just done for 1.5 hours, but value only gets created when the available solutions actually reach the patients in need. And we have still so much to gain there. So that would be my closing comment for today. Let's partner to make that happen.
Thanks for that. Teus, are you still there? Yeah. Also
yes, absolutely.
And I know we're almost over time, but I also want to get there was a question for you that's like, that was really that you were impressive that you were able to both improve outcomes and cost. And the question is really interesting. Is what was impossible before applying? Why was value-based healthcare needed for that? Was it not possible to do that without value-based healthcare? Can you briefly say that in 1-2 sentences?
Perhaps the statement is one sentence. Value-based healthcare, the theory, made me aware of the very strange way we worked so far. So value-based healthcare created for me new horizons for more patient-centered work. And that was it. That was for me the big motivator. All of a sudden I realized, because many of you will have had the same experience, once you realize what we are doing, that's quite strange that we pay people for services but not for what they at the end are able to reach. So not for outcomes but for service. And that was what value-based healthcare did for me.
Yeah, and actually, as you say, it's almost as simple as that. Focus on the patient.
As simple as that.
Yeah, it's
because we are all running in a certain system, and the system is full of wrong motivators, and it has a huge lack of real motivators, because it's very motivating to work for value and to work as a team for creating value. That's much more motivating than talking about how many people did you see.
Yeah,
that's not too much motivating. It's actually frustrating. But creating value with a team is really motivating.
All right, and maybe as a final closing remark, Gerard, any thoughts you want to really leave behind with the audience that's still there, which is quite
I first want to thank the audience for staying along with us for an hour and a half, which is quite long in a virtual setting. And my final sentence is, we talked value, but I am really a strong believer that a lot of value can be created already today, not by even measuring outcomes, but by better cooperation and coordination between care providers. And you don't need any IT infrastructure for that. It's just start doing it. You will already gain a lot, I think. And there is a lot of value to be gained. And we have to move, because there's a huge, well, we now have a COVID patient wave, but there is a huge wave of elderly patients coming. So nobody should be afraid of being out of business. We need to be prepared, right, to treat these patients in the future. So my invitation to the total audience is, help us in this journey. It's time to act now, and we need to work together across all stakeholders, and that includes also policymakers, because they need to also shape the system that is rewarding quality over volume. That's my final statement.
It's a clear one. Thanks, Gerard, and thanks to Janneke, FH, Teus, and all participants for being with us, and the great comments made, questions raised, and points made. There was one question: how will the recording being made available? We will summarize this webinar in a short report and summary, and we will include a link to that and to the recording, and share that with participants, so people can hopefully share this broader, because I think it was a very valuable discussion. So I would say, I'd love to say, spread the word, and let's do spread the word. So in this technical environment, spread the recording afterwards. So again, thanks all, and let's improve healthcare for patients.